Hi, welcome back to Smiling Healers. Today we are discussing metabolic alkalosis. Often I find a resident finding it difficult to understand metabolic alkalosis. Metabolic acidosis they manage well. So let us discuss metabolic alkalosis in just a brief way. Metabolic alkalosis is a condition where the pH of the blood is more than 7.4, right? Metabolic alkalosis can be of two types, right? One is chloride deficient, that is the amount of chloride in the body is less, and one is with normal chloride value. The condition where there is a decreased amount of chloride in the body includes all GI losses, suppose excessive amount of vomiting, yeah, excessive amount of suction from the nasogastric tube, or there can be dehydration, or overuse of diuretics. It can also be associated with transcellular shift, that is more common in hypokalemia. It can be due to massive transfusion due to the citrate in the blood. And if it is of normal chloride level, it can be due to mineralocorticoid excess. Okay, we have two causes. We have two types of metabolic alkalosis. The second thing is, whenever we see a metabolic alkalosis patient, two things we have to understand: that the PCO2 of the patient will be on the higher side because body try to compensate that alkalosis. Okay, and whether the compensation is complete or not, we can find out the formula with delta P is equal to 0.7 into delta bicarb levels. The second thing that we have to understand is metabolic alkalosis patient will have a low PO2 level and normal saturation level. This mismatch is due to metabolic alkalosis bind oxygen more strongly with the hemoglobin, so there is a leftward shift of the dissociation curve. So the tissue delivery of oxygen is decreased, so PO2 may be on the lower side in these patients. Whenever you see a patient of metabolic alkalosis, the first thing you have to do is urinary chloride levels. If the urinary chloride level is less than 15 milliequivalent per liter, then you have to understand that the patient is having a deficit in chloride. Now you have to calculate the chloride deficit. That you can do is 0.2 into weight of the patient minus, if you take 100 as a normal chloride level, minus the plasma chloride level of the patient. Now from where you can find out the deficit. Now this deficit you can replace by giving 0.9% NaCl. If you give 0.9% NaCl, then the amount of fluid required is NaCl has 154 milliequivalent of chloride. So the amount of volume that you will be giving is chloride deficient divided by 154, and we'll be getting the amount that is usually around from 100 to 125. But if a patient is edematous and if you cannot give 100 to 125 ml per hour fluid to that patient, then what more you can do for your patient? The more you can do is you can start the patient with acetazolamide. Now acetazolamide is only given to patients where we cannot give the NS due to the edematous condition or fluid overload. But if the pH is more than 7.7, that is, if the pH is life threatening, then the only indication in such cases is IV acid, IV HCl, that should be given by central line, not by peripheral line. This is the only condition where we give IV acids. Okay, so this is a brief approach to metabolic alkalosis. Let's meet on the next video with some more interesting topic.